On behalf of ISA Sangli Mirrors branch, I would like to extend a warm welcome to our esteemed guests, speakers, and delegates. It's a beautiful day to come together, share ideas, explore new possibilities. We are thrilled to have you all here for the PG Assembly 2024. Before the exciting session waiting for today.
Good morning, everyone. We have a very exciting sessions waiting today, which are promising to be an engaging, informative, and helps to refresh our anesthesia knowledge. So before moving ahead, please help yourself to the refreshments and take a few moments to review the conference program. So without further ado, let's get started. Our first session will begin now. Before that, once again, thank you for joining us and let's make today a productive and enjoyable one.
Understanding anesthetic care for older patients depends on varied factors and requires a detailed knowledge of physiology. The first lecture for today's program is Anesthetic Considerations in Geriatric Patient Posted for Hip Surgery. I request our beloved sir, Dr. J. Balavenkata sir, to enlighten us regarding the topic. Sir, please. I also welcome chairpersons Dr. M.V. Bhimeshwar sir, Dr. Ashok Deshpande sir, Dr. Kiran Joshi sir to chair the session. Dr. Bhimeshwar sir needs no introduction. Sir has been past president of ISA and controller of examinations and registrar for Dr. NTR University of Health Science. Dr. Ashok Deshpande sir is a consultant anesthesiologist with 42 years of freelancing experience and is invited faculty at World Congress of Anesthesiology at Dubai. Dr. Kiran Joshi sir is a consultant anesthesiologist with experience of handling difficult airway surgery, onco, special ENT and ortho surgery. Now I request chairpersons to introduce our speaker, Dr. J. Balavenkata sir.
Yeah, good morning everyone. I welcome you for this first session, and everything started off in time, the flag hoisting and all, and without wasting much time, I would like to invite Dr. J. Balavenkata to come on to the dais, and then he'll be talking on anesthetic considerations in geriatric patients posted for hip surgery. Bala needs no introduction. However, it is customary. So Bala is now the president-elect of the Indian Society of Anesthesiologists and the Secretary General of the World Federation of Society of Anesthesiologists. Dr. Bala, please.
Good morning, everyone. Respected chairpersons, senior members of the profession, and dear postgraduates, it's an honor to present this topic in front of the academic chairman of the ISA National, Dr. Bhimeshwar sir, the past GC member from the same soil, Ashok Deshpande sir, and my CR who taught me how to do a spinal and how to intubate, Dr. Kiran Joshi, past Vice President of ISA National, Dr. Meenakshi Sundaram, the current GC members in the ISA National, Dr. Manisha Katikar and Dr. Pankaj Gupta, the President of the vibrant state of Maharashtra, the ISA President, Dr. Anita Nete, President-elect Avinash Bhosle, Treasurer, Dr. Vikas Karne, the vibrant Secretary, Dr. Rajesh, and I'm truly happy and thank all of you from ISA Sangli MIRAJ for having taken up this responsibility to conduct the ISA-sponsored PG Assembly in this beautiful twin city of Sangli and MIRAJ. And I thank the entire organizing team led by Vasudha Madam, Dr. Rupali, and the entire team who have worked hard to make sure that this 3 days of academic extravaganza helps to enhance, to acquire the knowledge that it is needed, to acknowledge to the world for making each one of them a postgraduate, to the teachers, to the parents, and the patient who teaches us every day. So that's what the meaning I perceived from acquire, acknowledge, and then you make sure that you adopt it in practice, all that you have acquired. And the AAA ratings are very important in financial sector. And similarly, this meeting of acquire, acknowledge, and apply is at AAA, and I'm sure this is going to be an excellent academic extravaganza. I actually made it a point to start all my talks with 2 slides until every single anesthetist comes to know about this. This is a quote which really provoked me to do better every day, and I read it once at least every day in the morning when I get up. We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause an industrial revolution. We may be born to illiterate parents, but we can die as a scholar of world repute. We may have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be. We are so blessed and gifted to be born as a human being and as a professional and as an anesthesiologist. And I consider anesthesiologist as the most important medical specialty, because every surgical patient who comes to the hospital for a surgery, if you do an audit, number one, they're very afraid whether they'll die during the procedure. Number 2, they're very afraid whether they will have severe pain. And in the whole of universe, there is only one specialty which can preserve life and prevent pain, and that's anesthesiologist. And we should feel very happy to be a part of the process of giving this to our patients. In the process of becoming the best, it becomes important why some of them scale such heights and why some are not. Every postgraduate has to think it is the same class, same patient, same teacher, same book, same journal, but some scale such heights and others do not. So what was the difference? And the difference is here. Keep asking yourself, my future comes from where my time goes. So where should my time go? For everything that you want to do, you need to have the time. In essence, we reach a point in life when time almost becomes our God. All the postgraduates have to utilize this tool in the most appropriate way. This can take you away or this can make you to succeed. And it depends upon how much time you spend on this, valuably and invaluably determines your success. Excellence is never an accident. Masters make everything look so simple. The most brilliant of the best do their craft with effortless ease and exceptional grace, or at least make it look that way to you and me. When you see the stalwarts in cricket hitting a 6, it looks effortless, but hundreds and hundreds of hours and toil have gone into that before they make themselves capable of hitting such an effortless 6, and that's true of every profession. India, with 90 million people over the age of 60 years, leads the world in having the maximum number of geriatric population in this world. And it is also important to know the third commonest cause for any patient above the age of 60 to come and get admitted in a hospital for a surgery is a hip fracture. Because in India, osteoporosis is rampant, vitamin deficiency is rampant. At 60 years, they think that the life is over, and many of them confine themselves to the house with no sunshine hitting them, and osteoporosis is a huge problem. So even for a trivial fall, they develop a fracture. There's nothing homogeneous in this world as 2 newborns. They're just identical. Sometimes it's even difficult for the mothers to identify their kid in the NICU. But what happens in the process of our growth, we completely evolve as absolutely heterogeneous in everything that we have, the internal milieu, all decided by the environment and influence and the genetic factor. We wish to be like this, but unfortunately, no. The biological clock works and the wrinkles appear. We try our best to hide it. But as you grow, there are 2 different ways to grow. One should be like Kiran Joshi, doing trekking, mountaineering, and looking young, like 30 years old, like his son, the brother of his son. but many of them are not. If you see in this picture, the one on the left side is 94 years old. Absolutely brilliant hip fracture. The one on the right side is 62 years old. See the difference in the way they have lived. So it becomes crucial and important. Even when you age, you can age gracefully. In hip fractures, the global challenges are the perioperative care of geriatric patient with hip fracture is less than exemplary in major parts of the world. Organizational and anesthesiologist concerns delay surgery for more than 48 hours. This is very important take-home message. A great proportion of patients are managed conservatively for fear of death. Junior surgical team operating with prolonged surgical time and blood loss, and post-operative care given by orthopedic surgeons who do not know the physiology except fixations, which results in a passive and intermittent treatment resulting in phenomenal amount of morbidity and mortality. So, prolonged hospital stay and they acquire infection. The solution is continuous specialized medical care throughout the perioperative period, either solely by anesthesiologists who work as a perioperative physician, which we did in our hospital. Currently, it's a 650-bedded tertiary care referral center with 38 operating rooms with 150 surgeries per day with at least 12 hip surgeries every day for hip fractures. 90 anesthesiologists look after these patients. We have weaned off all the physicians from the hospital. Pre-op, intra-op, post-op are all done by the anesthesiologist, and I'm happy to say the outcomes have become better because there is only one leader who makes sure that. So the surgeon does the drain removal, mobilization protocol. Everything else is done by the anesthesia and the team. There is a ward anesthetist and 14 anesthetists are on call in the night to look after all the surgical patients and also to give on-arrival block to hip fractures when they arrive, even at 2 a.m. at midnight. And this has made a huge difference in the outcome. And one of the reasons possibly that we have become extremely popular as a surgical unit is not only because of surgery, but because of the perioperative care led by the anesthesia team. So this was statistics for 2022, 1,525 hip fractures. It's important to know what you treat. There is a lot of difference even in the hip fracture, intertrochanter, neck of femur, subtrochanter, and I'm going to share with you some of my thoughts. So what is our protocol? What we do? So a patient comes to the emergency room, seen by an orthopedic team. X-ray, ECG, blood investigations are done in the lab which is adjacent to the emergency room, and immediately it is shifted to the anesthetic room. So preoperative assessment by anesthetist is done 24 hours a day. We put a litmus test. Patient has to be seen within the first 1 hour of his arrival into the hospital by an anesthesiologist. Counseling and informed consent, starting intravenous access, IV fluid. Many of them are highly dehydrated because of the pain. They think if they drink water, they have to pass urine and they don't want to take. And so they are highly dehydrated, and immediately on arrival, we block, ultrasound guided block. I'm going to enumerate what it is. 60-minute observation in the block room, and then they are shifted to the ward until otherwise they're ASA grade 4 or grade 5. So then on arrival block, the protocol that we do for hip fractures, if it's neck of femur fracture with intact capsule, less pain, and we go for PENG block. If it's neck of femur with capsular disruption, because the anterior capsule has got a maximum number of nociceptors and it's extremely painful. So an anesthetist has to know what block he's going to do based upon the tissue injury. So we give PENG or either SIFI block or a femoral block based on the expertise. Intertrochanteric fracture, we give femoral block or high volume PENG. Intertrochanter with subtrochanteric extension, we give femoral block. So this is just to give an idea. So that's the neck of femur fracture. So this is an intertrochanter fracture. This is an intertrochanter with subtrochanteric extension. So as an anesthesiologist, it becomes important that we first see the X-ray to know what this patient has got and what is going to be the consequences. It's very important to know the neck of femur fractures have the highest morbidity and mortality in the world. And the intertrochanter fractures has best outcomes. That is because the blood loss in the neck of femur is very less. But they lived a life where the activity of daily living is so poor, so osteoporotic, and they developed a neck of femur. But to develop a trochanter, you need to have such high physical force which results in the bone to break. That means their internal milieu and physiology is excellent. One X-ray immediately puts into you what you need to do. Neck of femur, high alert. Trochanter, we are okay. So you can afford to do little mistakes, but neck of femur you can't because the morbidity and mortality is very high. When they are not fit to undergo a procedure, for example, this patient with hemoglobin of 5 grams, cognitive dysfunction of the elderly, severe electrolyte imbalance, sodium of 110. So we can't operate the patient immediately. We need time, but at the same time, we need to make them pain-free. So this patient, you see the elastomeric pump, gets a continuous perineural femoral catheter to make them pain-free until the 3 days that you take to correct the internal milieu. So it's very important and crucial. The block room is well equipped, and make sure that any complication arising of the block is treated. And I urge all the hospitals to introduce the concept of the block room. The important history for all the young postgraduates, when you see a hip fracture, first you need to ask them whether there was loss of consciousness, whether it happened after the fall or before the fall. Very, very important. If the loss of consciousness happened after the fall, it becomes important to do a CT scan because they are highly prone for subdural hematoma, extradural hematoma, because many of them are on antiplatelets. But if the LOC happened before the fall, we need to go to the root cause analysis. And the common thing in India is a carotid Doppler has to be done to rule out carotid artery stenosis, arrhythmias, middle ear disease, and vestibulobasilar insufficiency. And when a person crosses 40 years, that's the time when the organs started decreasing their function. For every year a patient lives after 40 years, there is 1% decrease in the physiological reserve of every organ in the body. So when you get somebody at 80 years, that is 40 years after he has lived that litmus age, or the shutdown, or I will say the cutoff of regeneration versus degeneration. So from 40 years, if somebody comes at 80, when you see a patient, inside your mind, you will say 40% of his lung is not working, 40% of his kidney is not working, 40% of his lung is not working. So the first impression is made, even if he does not have any comorbid disease. So poor reserves. And when you see 100 years, it is 60% decreased in the reserve. And fortunately for India, a lot of people live 100 years and more. And it's very rampant to have diabetes, systemic hypertension, coronary artery disease, chronic kidney disease, COPD, bronchial asthma, Parkinsonism, cerebrovascular accident, hypothyroidism, cirrhosis liver, in order of what happens in our patients. I've enumerated it. And of this, the most important thing is patients on coronary artery disease with antiplatelets. And our protocol is, my protocol is to go ahead and fix the fracture, even if they are on antiplatelets. I'll reserve this while we discuss it later, because the pro and con of life and death, pro and con between morbidity and mortality, waiting for 3 days to 5 days results in more morbidity and more mortality. That's our statistics. So if they're on alcohol, immediately supplement with thiamine immediately on arrival, and we start IV thiamine immediately. And if they're chronic smokers, put them on nicotine patch. Take a note of substance abuse. Please ask the question on constipation. The commonest cause of postoperative myocardial ischemia is straining at stools. So immediately for this patient, on arrival, we'll make sure that we start them on laxative. And if they're having special aids, like hearing aids, reading glasses, dentures, please continue to have them even inside the theatre. And if the sleep pattern is not proper, I think clonazepam, lorazepam, 0.25 milligram is a great choice in geriatrics to induce a natural sleep. And we need to actually look at the activity of daily living as an important parameter. So what we have seen is many of them are hypoxic. So in the preoperative assessments, important things are hypoxia, heart rate. If they have severe bradycardia, make sure if they're on beta blockers to stop beta blockers. Very high incidence of atrial fibrillation and arrhythmia. Hypertension is common. Hypertension is good. Hypertension, you need to be really careful because of the atherosclerosis. When there is hypotensive, there is high, or the organ hyperperfusion is very, very high. Keep a close watch on the urine output, and bladder catheterization is very, very crucial because the men have prostate enlarged, and a junior most catheterizes, he produces a false passage, urethral injury, and he came for a hip fracture and you gave a urinary tract infection, and he died because of urinary tract infection. So it's very important that you look at small things, and urosepsis is very, very high in women coming for hip fractures. And we need to look at the biochemical parameters. We need to transfuse to keep the hemoglobin at 10 grams per cent before surgery if they got a poor cardiovascular reserve. And we need to get into all these investigations which I mentioned. Very important is serum albumin. A serum albumin of less than 2 grams is an indicator of poor nourishment, poor activity of daily living, and poor outcome. So we initiate multimodal analgesia immediately on arrival. IV paracetamol is 1 gram is given. If the renal parameters are normal, ketorolac IV is given. Opioid sparingly used. Weak opioid patches are used sparingly based upon the intensity of pain. And Tependol nasal puffs are available now, which is excellent form of moderate analgesia. So I would wanted to say that was the first 3 hours. 3 to 24 hours, we decide to do the surgery within 24 hours. We try to get the internal milieu back to normal. And as I said, when he comes into the pre-op room, we will go for the checklist of consent forms, preoperative vitals, and anesthesia of choice is combined spinal epidural in our institution, but block before positioning. You give a block, make them comfortable and position. And block for positioning and postoperative analgesia slightly is different. For neck of femur with intact capsule, less pain, ping with LFCN. LFCN is for the dermatome because of the incision. Neck of femur with capsular disruption, pling plus CFI plus femoral plus LFCN. So intertrochanter, either femoral or high volume ping plus LFCN, intertrochanter with subtrochanter extension, femoral plus LFCN. So this is a formula that we have evolved and developed to give them the best form of analgesia. So clinical pathways in the operating room, pre-induction monitoring, and we go for 0-hour medication. High incidence of hospital-acquired infection, so we give them cefuroxime, that's the drug of choice for us. We use tranexamic acid to decrease the intraoperative bleeding, and multimodal analgesia starts with intravenous paracetamol, ketorolac, dexamethasone 8 milligram, even in diabetic patients, both for analgesia and for postoperative nausea, vomiting, ramosetron, pantoprazole, and if they are slightly delirious, we start them on a low-dose dexmed infusion. And you see this is a 110 years old, which did few months ago, and excellent outcomes when we use very low volume. So I've repeated it many times. I would like to say again, if they're more than 100 years, I give only 0.6 ml of 0.5% bupivacaine heavy. Between 90 to 100, you give 0.8 ml. Between 80 to 90, 1 ml. Between 70 to 80, 1.2 ml intrathecally, 0.5% bupivacaine, along with an epidural catheter to prolong. When you give such low volume, the two-segment regression happens within 45 minutes. So the top-up doses of 3 ml of 0.5% bupivacaine is started every 20 minutes. So intraoperative monitoring, which don't want to enumerate, but important thing is fracture positioning and the blood loss. We go for leukodepleted packed cells when we want to transfuse them to avoid febrile reactions. And when they use bone cement in neck of femur fractures, you have to be very, very careful of hypoxia and hypotension. Online warming and body warming is done for all the hip fractures because hypothermia produces more coagulation abnormalities. And we shift them to the HDU for the first 24 hours in the postoperative period. And pain is the most important thing, and we make sure that we go on to embark on blocks plus multimodal analgesia. DVT is very common. We go for mechanoprophylaxis with intermittent pneumatic compression device, and in morbidly obese patient, we go for chemoprophylaxis, and the drug of choice is low molecular weight heparin, which we give 40 milligram OD every day. And the common cause of hypoxemia in the postoperative period is the commonest complication, hypostatic pneumonia, microfat emboli, cement emboli, and pulmonary emboli, and transfusion-related acute lung injury. Hyponatremia is the next common thing we have seen. In general, hip fractures do very well if you operate them at the earliest, make them mobile at the earliest, and give them a lot of psychological support, look after their bowel and bladder, catheterize the bladder, use laxatives to prevent constipation, and a clear protocol on perioperative antibiotics. And it doesn't make a difference whether they are 40 years, 50 years, 110 years. It is up to the anesthesiologist to make sure he maintains the same blood pressure. If a person is living at 160/80, to maintain 160/80 throughout the perioperative period, you are not going to produce myocardial infarction. It's such a simple thing, and the simple thing can be achieved by your technique, technology, understanding, and being very, very careful on patient safety in the perioperative period. So we do the postoperative mobilization and discharge them on the 4th day. So we have to go for excellence in whatever we do. And the best thing is to make them live. As I said, we have the power to prevent death. We have the power to preserve life. And I think we can do it with distinction if we make sure that every single step that we take for our patient is the best. I always feel when I want to stitch a cloth, I want to go to the best tailor. When I want to go and buy a car, I want to buy the best car. For our patient who is going to give his entire life, am I the best anesthetist in town? This is the question we should ask ourselves. And if we do so, we know that all our gaps will be filled, and we will not give importance to any mobile inside the theatre when you are operating a 100-year-old. I think the whole focus goes on the perioperative care. I take this opportunity to welcome you all to the Ganga Anesthesia Refresher Course, which will happen between the January 30th to February 2nd in our institution, which will focus on holistic growth of each one of us, including ultrasound, target-controlled infusion TIVA, which is going to rule the world in the next decade, and research methodology, because we need to progress, point-of-care ultrasound, basics and advanced. It's a mixture of several things, and I take this opportunity to welcome you all. And as the President-elect of the Indian Society of Anesthesiologists, I take this opportunity to welcome each one of you to the National Conference in Patna, and thanks to the entire Governing Council for all the changes that we are making to make ISA more academic. I take this opportunity to welcome you and propagate the information that the ISA National GC decided to conduct simulation-based learning to decrease perioperative morbidity and mortality. A curriculum has been formed based upon the incidence of morbidity and mortality in India. 18 centers have identified, 18 mentors have been identified, and the first session is going to start in the zone state of Maharashtra. Thanks to the leadership of Maharashtra and leadership of Pune ISA, on October 13th, next Sunday, ISA simulation-based learning will open up with a single intention to make every single anesthesiologist capable of learning everything that he has to know to decrease perioperative morbidity and mortality. I'm sure we'll go strength to strength to make ISA one of the best organizations in the world. As the Secretary of the World Federation of Society of Anesthesiologists, which is headquartered in London, it has got 150 countries as its member societies. I welcome and invite all of you to the next World Congress of Anesthesia to be held between 15th and 19th of April in Marrakesh, Morocco. And at least the visualization is 500 anesthesiologists have got to go from India, and with 500 presentations to tell the world that we are one of the best. And we are truly one of the best. But how does the world know if we don't go out and tell them what we do? So I would wanted to tell to Vasudha Madam and Rupali that to take on them that you will come first yourself, and you will bring at least 50 from MIRAJ-SANGLI and Kolhapur to show the power of what you do in smaller areas. And thanks to two of them who presented in the World Congress of Anesthesia, last time Kiran Joshi for his wonderful work that he does in Sangli, and thank you so much Amruta Datye for showing to the world what you do in Miraj. So this has to happen to everyone, and I would wanted to enjoy the delight of India everywhere internationally. And thank you so much for your patient hearing. And together we need to build a society that will respect us and that will really give importance to anesthesiologists, because we are the best branch on earth in preserving life and preventing pain. And we are very fortunate to be here. And I'm very happy to be in Maharashtra, and especially in Sangli, because I've almost delivered 800 lectures nationally, but my first lecture was in Sangli, in the ISA CME in Sangli, and Ashok Deshpande sir was spearheading it. Thank you very much for giving me an opportunity to climb the ladder, and thank you so much for each one of you for the support you gave me in me having the possibility to hold the current responsibilities in ISA. Thank you so much.
Thank you, Dr. Balavenkata, sir. Yeah. It was a very nice presentation and detailed presentation. I just wanted to ask you one thing on behalf of, sir, please, on behalf of all my colleagues who are sitting here, because they are doing these hip surgeries every now and then, but they may not be provided with all the equipments which you have or which district places have. Sometimes they face this at taluka places. So, what exact procedure they should follow for safety of the patients?
Sir, I feel there is only one thing in the world which will assure patient safety, and that is the knowledge, skill, and wisdom of anesthesiologist, and it is not the infrastructure.
Oh.
So, as I said, the willingness, the attitude, the focus, and make sure that everywhere there is ECG, everywhere there is pulse oximeter, everywhere there is a non-invasive blood pressure monitor, even in the taluka place. And now we need to devise a technique to see this monitor and make sure the monitor before giving anesthesia and after giving anesthesia and in the post-operative period, monitor number doesn't change. This is the only take-home message, sir. Yeah. And if that monitor remains the same, patient will live. And I don't think we should say that we don't have infrastructure. Because if you go to Africa, then you will know where we are. We are living in heaven. I will just quote only one small thing and stop. There was one, we trained WFSO fellows from Africa. There is one fellow from, I don't want to mention the country. So he used to take only morning cup of tea and afternoon a cup of tea and biscuit. So after some time I gained courage to ask him, why are you like this? Is it that you are on diet? He said, no sir, the country where I come from, the money that they offers me only one meal a day. Because I have to look after my wife, I have 2 kids, they have to go to school. Every penny that I spend, I calculate. If I take breakfast and lunch, I cannot save money to send my children to the school. Just because I am here, I don't want to spoil myself by eating a big breakfast and big lunch. I want to preserve my emotions so that when I go back, I will live the same life. Where are they and where are we? We are blessed to be born into this country, and it's our duty to push this country forward. Thank you so much.
We can have some few questions from the audience if they want.
What is your protocol about, as you said, maintaining the blood pressure? What was there in the pre-operative, intra-op, and post-op? Whether you preload the patient or you give them a vasopressor, and what is vasopressor of choice? And secondly, about antiplatelets. The patient having recent stenting?
Yeah, 2 very important questions. As I said, number 1, the time of fall and they coming to the hospital is first important thing. If they come immediately, they're reasonably well preserved. But many times there is a big conflict going on in the house whether you have to operate a 90-year-old. So they come after 3 days, 4 days, 5 days, and they're grossly dehydrated. So the time of arrival to the hospital and the time of injury is very important. And so first thing is to enrich the internal milieu. But at the same time, we need to keep in mind the possibility of left ventricular dysfunction that is present in very large numbers. So it is to be, and also there is no response of heart rate for the hypovolemia in geriatric age group because of the high vagal tone. So heart rate does not show how much fluid that he needs. So, but most important criteria in this, I'm talking in taluka place. So, the most important thing is catheterize the bladder, give fluids to the level that you produce 1 ml per kg of urine per hour. So, that is the fluid that is needed to make the internal milieu better and volume status to be good, number 1. Number 2, as I said, my choice of anesthetic technique is combined spinal epidural. Even if the surgeon says, I will finish the surgery in 20 minutes. He will finish in 20 minutes, that is perfectly fine. But I will produce a hypotension by giving only spinal, and 5 minutes of hypotension will take away the life. So I tell, and it's an understanding now, the decision of anesthetist to use a combined spinal epidural is to maintain the hemodynamics similar to the preoperative level, and it is not equivalent to the surgical duration of the surgeon. And I argue with them if they say cost is a factor, because the amount of drugs that you use after hypotension and shifting this patient to ICU is 50 times more than an epidural cost. So combined spinal epidural, low volume spinal as I indicated, maintaining the mean arterial pressure 15% above or below the preoperative level throughout the process, and making sure that they remain in the high dependency unit to make sure the pressures are the same. Within 24 hours, majority of them stabilize. Even if you are working in a taluka place, even if you are working in a place where there is no cardiologist, there is no pulmonologist, and you have to do a hip fracture, I think these simple things are important. Maintaining the urine output, maintaining the hemodynamics throughout the perioperative period for the first 24 hours. After that, all of them do extremely well. And for the question of antiplatelets, now it's very clear that the morbidity and mortality increases if you delay the surgery. If the surgery is done within the first 24 hours, the outcomes are excellent. Now, the question, what anesthesia to give? Again, I'm keeping everything at the level of taluka place, whether to give a GA for a 90-year-old or go for a combined spinal epidural for a 90-year-old. So my choice, that even today, sir, this is since not for the postgraduates, but for all the practicing anesthesiologists, even today, when a patient comes with clopidogrel and aspirin, and suppose he had a stent, if you stop clopidogrel and aspirin, he is going to die because the chances of restenosis is very, very high because of the platelet plug formation. Now, it is the wisdom of the attending clinician to decide which is best for the patient. So, even now, I do combined spinal epidural in a patient with aspirin and clopidogrel who had a recent stent, and the only difference is we talk to the patient attendant, explain to them the pros and cons, and the surgical team take a written informed consent. And most of the times when you explain to the attenders, all that they say is, sir, what will you do if it is your father or your mother? So I tell them that the same thing I will do. So if they say that if it is so, please go ahead. And I tell them the complications are, there can be a possibility of, a rare possibility of a epidural hematoma. But I also tell them, in my 30 years of life, I've just seen only one case. So, but having said this, I also wanted to, there is so much is happening on antiplatelets. We are happy to be in Asia for several reasons. And one of the reasons is the clopidogrel that is taken. The recent research has shown only 60% of the circulating platelets are getting affected by the dose of clopidogrel that you give in Indian population. Is a recent research. So 40% of platelets are still functioning, and also every day 15% of more platelets are getting produced. So for example, even if the day immediately you don't do like in our center, it takes one more day. So 15% new platelets have produced, and 40% of the circulating platelets are not affected by clopidogrel. So you have almost 50% of platelets doing its activity, and that is possibly the reason why in Indian population that epidural hematomas are so rare compared to what you see in the West. This is a research, evidence-based, but in spite of this finding, I would strongly recommend you need to evolve practices for your own institution, excellent relationship with the surgeon, and anesthetist talking to the patient and the patient attendant, explaining to the risk, and going ahead, getting written informed consent and going ahead and doing surgery. Because, sir, all this is because what we have experienced over a period of time. There was an era when we stopped antiplatelets, and there was an era when we lose patients because of a reinfarction and death. So whether we wanted that, so everything what I'm speaking is an evolution that has happened over a period of time in a focused manner of treating these patients.
Good morning, sir. Myself, Dr. Mohan Patil, practicing almost for 35 years in
But you look very young, sir. You don't look like that.
Thank you. Everybody says like this. Sir, almost 35 years I am practicing, but in private sector. All the time surgeons are insisting to have a surgery as early as possible because they are worried about the patient getting transferred from his hospital to another hospital. So what I am following is pre-operative blood transfusion for 2-3 transfusions. And my experience is with this blood transfusion, little time we get 2-3 days to get patients settled down in the hospital, and hypotension during spinal, of course, I am using low dose spinal, is very less because of pre-operative 2-3 blood transfusions. What is your opinion about this?
Number one, my opinion is 35 years of blood transfusion in geriatric patient, you should have published your work now. That's number one. The most important thing, data is important when we speak. And why, in spite of doing good work, it's not known to the world is no data. So, sir, I completely respect what you said, but first thing is, probably you are going to give to the world some new theme of preoperative transfusion in preventing excellent outcome. But if this has to be documented. All the new findings that has happened in this world has been because of documentation and audit. So number one is that. So I'm happy that you found a technique and technology to prevent preoperative complication and improved outcome. But this has to be documented, researched, audited before we accept it, number one. Number two, giving transfusions, the world is moving towards less transfusions because of several factors. Number one, transfusion-related acute lung injury is very common. Then, if it is not leukodepleted blood in geriatric patient, having post-transfusion shivering and fever is very high. And number three, getting 3 units of blood and transfusing in the preoperative period is another big concern in several units across this country, if you take the country as a whole. But however, I am a person who believes in minimum transfusion to the patient. And to the concept of hypotension not happening is maybe because your intravascular volume became better, but that intravascular volume could be made better even with crystalloids and colloids for the time being. It's only the little time until they start eating well and drinking well. So my personal opinion is it's a good finding, but please document it, sir. And as of now, there is nothing in the literature which will say yes to you. So you should be the first one to contribute. So why don't you present this in the World Congress in Morocco? Sir, Ashok sir, please bring him along with you. It is a challenge to him, and this is how we grow. And sir, please come.
Hello, I am Dr. Satyanarayana from HL Karanji.
Sir, this is the last question, sir.
Yeah. Is there any role of a prophylactic digoxin intraoperatively? Is there a role?
Yeah. Sir, I think it's an excellent inotrope. But to digitalize a patient who has come in, it has to go for IV digitalization. Yeah. So, so the point is, we do not know what is going to happen, the digitalis toxicity, the potassium levels, and what are the other medications he's taking. So, again, everything has to go by evidence. So, in my personal opinion, I think the simplest way to do it is to preserve the hemodynamics without anything. I don't believe in polypharmacy. Patient lived with 160/80. I want him to live 160/80 pressures intra post-op with minimal intervention into his physiology for good outcomes. Thank you very much, sir.
Yeah, thank you, Bala, for that wonderful presentation and a wonderful interaction. But due to paucity of time, we couldn't take more questions from the audience. Now we come to the end of this session. Thank you very much.
Thank you, sir, for an elaborate and informative lecture and giving us the practical tips towards the management of geriatric patient. I request chairpersons to felicitate Dr. J. Balavenkata, sir.